This is the Emergency Medical Minute, sponsored by CarePoint and HCA Health One.
Great. Okay. Good morning. So yesterday we did hyperkalemia. Today we're going to do hypokalemia, and mostly because it lets me talk about two of my favorite things. So first of all, how we get it. So hypokalemia, we talked about some drugs yesterday that will help us lower the potassium in patients who have probably some renal dysfunction and therefore have gotten some increased potassium. One of those was a diuretic, Lasix. And so diuretics and meds are probably the most common way that you start dropping your potassium. We also talked, just for a fun sidebar, about how some things can shift your potassium. Albuterol was on that list. It doesn't meaningfully excrete any of it, so it is temporary. But if you have a patient who's come in with respiratory distress and we have them on, say, continuous albuterol, that's one way that the potassium can become shifted, and you can see a slight drop in that. Again, it's temporary. We don't usually treat that. In patients who have high GI losses, so a lot of times in gastro season, if somebody comes in with gastroenteritis, any kind of GI loss can cause your potassium to go low. So lots of vomiting, lots of diarrhea. We also will see it in a more kind of chronic sense in patients who have like chemotherapy that makes them really sick to their stomach, or just chronic diarrhea for other reasons. So GI losses will definitely cause your potassium to go down. So once you have identified somebody as being hypokalemic, one of the changes that they get is on their EKG. And so you can end up with this tiny U wave that happens on the backside of their T wave on their EKG. And when I was in medical school, I did a cardiology class over at National Jewish. And there's this old cardiologist who sits there and talks to you about EKGs and spills everything he knows about them. And it's such a fun and fascinating class. But what he said was, if you're looking at somebody's EKG and you see this little bump after the T wave and you go, is that a U wave? And your voice sort of goes up at the end, that's how you know it's a U wave, because you're not really sure. You're like, is that a U wave? And then that's a U wave. That's how you know. Those can actually fuse together and become this TU complex, and that can actually be a lot harder to identify, which is a bummer because that's when it becomes dangerous. The TU complex can fuse, and it actually does prolong meaningfully. It's not just like a visual thing. It prolongs the repolarization of your heart, prolongs that QT prolongation, and puts you at risk for, VFib, VTAC, torsades. So not just an artifact at that point. We see patients that come in with low potassium all the time, anywhere from kind of 3.5 to 2.5. Those can probably be repleted orally, and also need to think, if you're repleting them, you need to give them magnesium at the same time. Hypo-K is hypomag. So you'll oftentimes see that happening at the same time. When they get to be below 2.5, those are patients who really do need IV potassium. And you'll probably see us sort of flirt with the idea of bringing them in at that point, as opposed to trying to treat them to completion here in the emergency department. Other things that can cause hypo-K, which brings me to my very first favorite thing to talk about, is this thing called hypokalemic periodic paralysis, which is patients who end up with just these periods of dropping their potassium, and it creates this paralysis, mostly concentrated in the lower extremities, but their upper extremities do tend to see some effects. It's a channelopathy, so it's actually just a way that their cells deal with potassium that causes this. And the YouTube videos of this are very, very fun. So these patients will, thank God, sometimes have some mobility in their arms, and they will keep these little cups of the oral potassium, like the orange one, next to their beds. So if they end up waking up one morning and realizing that they have this and they're completely stuck in bed, they can reach over, hopefully fumble for some oral potassium, drink it, and then wait a spell, and then be able to start moving again. When patients come in for the first time, they usually only come in for the first diagnosis of this. And when they come in for the first time, they tend to be in their 20s. So it's they don't really come in with their parents. It's the first time they're living alone, and they just wake up one morning and can't move. It's really profound. The YouTube videos are worth a watch. Happens in Asian males most commonly. I've seen it in some other males, but I don't think I've ever seen it in a lady. Not that I remember, but it's a really interesting disease process. We talked about how this QT prolongation can lead them to dangerous arrhythmias, which now lets me talk about my second favorite thing to do with this topic, which is refractory VFib. Yesterday, we had a cardiac arrest that we were coding for a while that had a shockable rhythm one time. So unfortunately, that wasn't him. But in patients who have this VFib, where every time you're checking, they're in VFib, and we're shocking, we just can't get them out. 3 things that you can try to do for refractory VFib to help fix it. One is esmolol. There's very, very small study that shows that maybe that is helpful. So it's a pretty big bolus, sometimes followed by a drip, but that might be a helpful reset for the heart. And then the other thing is a double defib, which we were talking about yesterday. Pads go in your normal position, so anterior and lateral. and then one goes posterior and the other one goes just to the side of the anterior pad that you're using. The goal is to kind of try and get the shocks close together. It's almost never exactly at the same time, so it tends to be sort of a sequential double defib as opposed to a truly, concomitantly shocking them at the same time. So worth a try. And then the last thing that we already mentioned slightly this morning was that for refractory VFib, you can end up trying ECMO. So if the reason that this is happening is just that the myocytes are angry because they're not getting enough oxygen because of their MI, giving them some oxygen back, kind of taking them off, of their normal circulation, putting them on ECMO, giving back oxygen to the myocytes, and then giving yourself a chance to go in and open up the affected vessel may be the thing that helps. So like we said, not something that we're doing right now, but coming soon to a Swedish near you. Any questions? All right, let's have a good day.
This has been the Emergency Medical Minute. Thank you to our sponsors CarePoint and HCA Health One. Support from them and listeners like you helps us to continue providing free medical education to the masses. If you found this episode valuable, consider supporting our work and check out the link in our show notes.